Hope you're all doing well, and hope you had a good evening yesterday, good dinner, what have. And I'm going to be talking about safety in obstetric anesthesia, specifically how to use a QI program, quality improvement, as opposed to the usual safety lecture where we talk about how not to get needle sticks. I have no conflicts of interest. Patient safety is important. We all want patient safety, right? None of us wants to harm or injure anyone. But our patients are at risk, mostly because people that we take care of are in poor health by definition. And so they are at more risk of something happening bad, an adverse event or a complication, or suffering the side effects of anything that we do. Like all of our medicines and procedures have side effects, and sick patients are going to be more likely to suffer them. And finally, healthcare is one of the most complex industries that we have out there. If I hear one more person talk to me about the airline industry and how airplanes land on time, I'm going to throw something at them. This is a much more complex industry, and so the things that we need to do in order to improve patient safety are going to be much more complex than just the simple things like training pilots on a simulator. Our goal, of course, is to provide healthcare which is free of accidental preventable injuries from what we do. Errors happen for several reasons. One reason that they happen is what's called an active failure. In other words, something that we do or fail to do injures a patient or causes harm. There are also latent failures, and most industries have begun focusing on latent failures, and medicine is far behind in this process. A latent failure is something that is as a result of our workplace or the system of how we care for patients, and that can be time pressure or staffing, it can be equipment, or it can be something like having the alarms go off in the ICU, right? We've all experienced that, where there are so many alarms on the labor floor of the ICU that people just ignore them and you don't even pay attention to what's going on. So that is a systems error due to a latent failure. And I just want to encapsulate what these failures actually mean. This is an active failure, right? The person drove the car into the pond. They did it. It's an active failure, as opposed to a latent failure. And this is a little bit more subtle, right? This person is going to grab the book at the top of the bookshelf, but they're using the wrong device to do it. And they may be able to do it 100, 1,000, maybe 2,000 times, but eventually that chair will slip. They're going to fall and hurt themselves. That's a latent error. They should have the correct equipment in order to do the job. If we look at human error, there are a couple of approaches, and medicine has only concentrated until recently on what's called the person approach of human error. And the person approach is that people make mistakes. That's why we are all here, to collect our MOCA and CME credits, right? We want to ensure that we have adequate training, skills, and intelligence in order to do the job. And so what we do is we come to these meetings and we fill out our forms, which you have to do, and make sure you do it today. And we evaluate and we train people. We do this all the time. And when they have an error, when they have an adverse event, what we do is we reprimand them. And if they continue to do it, we fire them. It was that person's fault. Most higher industries with higher safety profiles look at a systems approach to error. It's not just people that do errors. It's also the system, the latent system underneath what we do. And they define it as a system that can produce or prevent errors. Systems then should be designed to try to reduce errors and also to make sure that when an error does happen, because they always happen, that you minimize what the outcome of that error is. And so I want to demonstrate some of the nature of the difference. And I'm going to use this one publication from last year, which was Obstetric Neuraxial Drug Administration error review. And what they did was they went into the literature and looked at all the case reports of times when the wrong medication was injected into the neuraxis. And they collected these and they quantified them and they broke them down into 9 different categories. And then they sent them out to regional experts to come up with systems of how that would be prevented. And I want to show you those systems in a very summarized form. Those systems were to label all your syringes, read all your labels, and double check the labels. Now, who did not get this instruction in their first week of training? Who does not try to do this every single time? And yet errors happen, right? This is the problem, that humans are fallible. Every magician relies on this. When you go to a magic show, this is what they rely on. They're going to trick you so that your eyes will not see what you're actually seeing. And this is the problem. Now, this is a person-dependent system. This isn't going to work any better than any other person-dependent system. The fourth system was the use of a non-Luer lock connector, and this is coming to the United States. The companies that supply our epidural equipment are already working on these non-Luer lock connectors so that you can't connect anything you would hook up to a normal intravenous line or other injectable forms of lines into an epidural connector. That's great, but that one requires that what you put in the syringe be correct. So it requires the previous system to work perfectly. So this is great, this is an advancement, but it's still not going to work perfectly unless the first three are connected, and we already know that they work most of the time, but not always. So I titled this as looking at a quality improvement program, so I wanted to find what the differences between the two types of quality programs really are. The first is called a quality assurance program, and that is a data collection system that we all have in our hospitals, and it's necessary, and it basically serves to make sure that we identify what the issues are in our hospital. We have quality indicator dashboards, and we have benchmarks so that we can compare ourselves to local and national or international processes. There is limits to this because it depends on how the quality of your data is. If you're not collecting information well, then you're not going to have a good QA system. And secondly, we tend to all go towards the QA measures. We've all done this, right? They said give antibiotics within an hour of incision, so we all worked on how to give antibiotics within an hour of incision. It doesn't mean that we did any better for our patients. It just means that we met the QA dashboard. I'm going to show case here, which is a 24-year-old Gravida 1 at 39 weeks, requested epidural pain relief. Epidural catheter was placed at L3-4 on the first attempt uneventfully. 3 cc's of lidocaine with epinephrine were administered as a test dose, followed in rapid succession by 12 cc's of ropivacaine and fentanyl as a labor analgesic. And within a few minutes, the patient had a high a high spinal, right? Blood pressure dropped, unable to move her legs. There was a fetal bradycardia due to the hypotension. They went to stat cesarean delivery. No additional medication was required. They did the entire surgery with that initial dose of labor analgesia, which was, of course, an intrathecal administration. Our QI program looked at this and said there was a stat cesarean delivery. Great. The baby was taken care of. It did really well. Regional anesthesia was used. Great. We didn't have to do a general anesthetic. From the QI perspective, it did not hit a dashboard. But we know we need improvement, right? There was something wrong with there. This is where the quality improvement programs come in. Quality improvement programs are engineering techniques. They're industrial engineering techniques that are mathematically and scientifically based that have been going on for 120 years in the textbooks of industrial engineering programs that we really haven't focused on in medicine. They're both retrospective and they're prospective, and they are systems-based programs that try to make the system safer so that human error doesn't affect patients as much. The goal of a QI program is to achieve a different level of safety in the system itself. There are several types of QI programs. I'm just going to name 4 of them, and what I have to warn you about is if you talk to any of these people, this is almost religious. They each fight each other over which is the better QI type of program. There's the Toyota Lean program, which the basic philosophy of Toyota Lean is to eliminate waste in the system. Multiple types of waste. They eliminate waste, and by eliminating waste, everything becomes more efficient and of a higher quality. There's the 3M Six Sigma program, which the goal of the Six Sigma program is to eliminate variation so that everything is done on a very tight window. You get the exact same product every single time, and then you can focus on changing the product as you need to in order to improve it. This is the Edwards-Demings Process Management Program, which is a cyclical improvement program, which is a continuous quality improvement program where you identify, and we'll go through these, identify what the quality improvement that you want is, and then you affect changes in order to achieve that level of change. And then there's hazard analysis, which is both retrospective. Root cause analysis programs are retrospective. The VA healthcare systems have really pioneered the root cause analysis programs. And it's prospective, which is what NASA uses to try to minimize the risk of yet another explosion up in space. This is an example of lean, elimination of waste. What you're looking at here is the workroom in labor and delivery, and what we've done is minimize the equipment, color-coded and organized it so that anyone who comes into this room can very quickly identify where the equipment is and grab it. Why does this matter? Sure, in my old workroom I could run in and grab anything, but if I'm in a pinch and I ask a resident or a nurse to go get X equipment and they're not familiar with this area, they can go in and come out in less than 1 minute, as opposed to trying to find, for example, a single piece of equipment like the air filter if a patient has a PFO. Well, it's in green, and so if I say, go look for the green box, they can find it and come out of that room in less than 1 minute. Or if I need that video laryngoscope, go grab the glide scope, and it's labeled, they can find it very quickly. Bigger example, eliminating variation. So placenta accreta is very common now, right? This is the consequence of having so many cesarean deliveries. It's about 1 in 750 deliveries has a placenta accreta of some nature. The median blood loss for these cases when they're surgical is 2 to 3 liters. So these are major cases, right? They are patient risk. We've all seen them. We've all had them. We know this. The presentation here of a case is a 33-year-old gravid 2 para 1 who had an increta from a previous cesarean section. She underwent cesarean delivery uneventfully, followed by huge blood loss from the pelvic veins around the increta. Transfusion was used to maintain her vital signs until bleeding was controlled, and we had a process in the place to make sure that variation was eliminated. So we had a multidisciplinary conference on this patient 1 month prior, 9 services all attended to make sure we go through a graded script to make sure everyone is doing the exact same thing each time, and we cover all the bases. There's a pre-op briefing where we bring all the parties into the same room and we go over the case, so we all have a shared mental model that we're all going to follow the same process so that everyone knows what we're going to do. And then we have very tight coordination with blood banks so that they have their own processes, and we work to make sure the variation between cases is very little so that everyone can judge when they need to deviate in case this patient is different. In terms of our checklist for our anesthesia residents, we have a very scripted checklist of what they need to do in order to set up the room and set up the patient to make sure. Why? Not so that they don't have to think, it's so that anyone who walks in the room can do the exact same case because everything is set up the same way. All the dumb stuff is taken care of, and then we can concentrate on taking care of the patient. Unfortunately, postoperatively, this patient had a hematocrit of 47, remained intubated for 23 hours, had to get diuretics for volume overload, and had oxygen requirements for over 24 hours. Right? So in this case, they were transfusing, they kept her alive, everything went great, but there was circulatory overload, and our QA system, she came up on the dashboard. But not for the planned ICU admission because we knew that she was going to go to the ICU after this increta, and not because of prolonged intubation because she was only intubated for about 23 hours, so she actually flew under that wire. She came up because we have to redose our antibiotics at 1,500 cc blood loss, and they didn't do that. And that's where the QA indicator came up, and I would submit that's not what she should have been brought up for. It was the circulatory overload, and that was the problem in this case, although the antibiotics are important too, I'm sure. Transfusion-associated circulatory overload does occur, and it occurs in about 3 to 5% of all surgical transfusions. The incidence after cesarean delivery is a little bit less, but that probably has to do with the types of cases that we do. C-section is the most common surgery in the United States, and so most of the C-sections that we deal with are fairly low blood letting cases, and so the number of circulatory overloads that we have, because we do have a patient population which is young and resilient, is very low, or a little bit lower than the general population. However, probably in these major placentation cases, that's where you're going to see this happen, and that's what happened in this case. One process would be to improve how people evaluate blood loss, and we've all seen examples of this. This was presented yesterday, which is training our people to learn how to better evaluate the amount of blood loss, right? So if we can estimate the blood loss better, or evaluate the blood loss better, then we can come up with a system of transfusing better. And it's true that you have to improve the quantification of blood loss, but the problem here is that's not the end target. What we're looking for is the amount of circulatory volume, right? That's what this patient had, a circulatory volume overload. So we want to identify a way of quantifying circulatory volume, and we don't have that system right now, but that is the desired outcome. Transthoracic echocardiography is probably the best measure of evaluating volume in the ventricles. However, it is a technology which is hard to teach everybody, and especially generalized settings. Another method, and the method that we chose, is to use pulse pressure variation. Pulse pressure variation is the changes in stroke volume that occur because of intrathoracic pressures and venous return. So this works on patients who are intubated and have positive pressure variation. And when you have inspiratory pressure, what occurs is there's a decrease in venous return. And if the patient is volume responsive, then that decrease in venous return is going to be more significant. And the change in pulse pressure between systolic and pressures during inspiration and expiration are going to be significantly greater. And any pulse pressure variation above 10 or 12 is associated with volume responsiveness, which means you can give more volume to that patient. And if it's below 10 or 12, then you don't necessarily have to give more volume because they're on a plateau for stroke volume. Which brings us to case number 3. And this is a case that demonstrates what we call Plan-Do Check-Act Cyclical Improvement Program. This is a 24-year-old gravid 1 term pregnant patient. She had a sudden onset of fetal bradycardia, and there was a stat cesarean delivery that was called. It took about 5 minutes for the patient to go from the labor room into the operating room, right? So there was a difficulty arranging the team, communicating with everybody. The system wasn't very effective. There were things in the hallway. There was a 15-minute delay once the patient got into the operating room to when the baby was actually delivered, partly because there was missing equipment. There were way too many people in the room, so communication was difficult, and the room was a mess. Everyone was yelling, things were flying up in the air. We've all seen stat cesarean deliveries. They're chaotic in the most cases. And there was no antibiotic administered to this patient. Right off the bat, you can see several problems, the biggest which was the baby was born with brain injury. So there was actual patient harm, not just theoretical patient harm, actual patient harm in this case. This was something that I was very concerned about because I was in this case, and I remember my resident talking to the patient, standing right next to me, just 3 feet away, and I could not hear what she was saying, right? It was that loud in the room. There was something that needed to be changed, and so what we started was in situ simulation program, not to train people, but to train our system, and I'm going to explain what that means. So this was a program where we did an in situ simulation of stat cesarean delivery every 4 to 6 weeks on an iterative schedule, and so we would have a simulated event. Right? We would do a stat C-section with people on the floor. We would go through the stat C-section, bring them all, do debriefing, identify what problems occurred. Then we would take time to go through the process and devise corrective actions. And then there was a few weeks of training staff on what those corrective actions were, and then we would test it again. This had nothing to do with training people to act better. This had to do with figuring out why our system stunk. Here's a simulated training that we went through. This was one of the C-sections, and I'm going to identify a couple of the problems that occurred here, and they're a little subtle, but I want you to see them because I want to identify what kind of systems issues that I'm talking about. The first thing you see on the left panel is the scrub and the nurse trying to get the equipment ready while the patient is moving out of the labor room to go to the stat C-section. The nurse on the left is trying to do something, and what she's trying to do is open up the equipment so that they can count the equipment so we don't have a retained instrument. She's trying to open the equipment. She's trying to open the equipment. And what had happened was we had gone from opening paper prepared safety equipment to having a latched box, and she can't figure out how to do it. You can see the box there. She's trying to figure it out. There's about a minute of time while the patient is coming down the hall that she can't figure this out. No one had adequately trained her, or they probably told her all you have to do is X, Y, or Z, and she couldn't figure it out. And the only way we would know that without this simulation is when the patient, a real stat C-section comes and she can't do that. Right? Finally, she got it open. It took about a minute to do that. We didn't know that we needed added training on there. Now here comes the patient in the room. I'm going to show you error number 2. Look where the patient bed is and look where the C-section table is. There's a good 12-inch gap right there, right? The obstetricians, when they called a stat C-section, had been instructed as one of the early identifying features of this to raise the patient bed. Why? Because the patient bed is often down where the obstetricians need it, but the C-section tables are much higher. And so the first thing they should do when they call stat C-section is raise the bed up to their belly button, and then we'll be able to move the patient more easily. They forgot to do it in the simulated environment. Why? That's a person-dependent process. Right? And people forget, people make mistakes. That's the problem with a person-centered approach. And what we had in this operating room was there weren't any plugs near the bed. So we would actually literally have to move the patient bed all the way over to the wall to plug it in, to raise it, and then bring it back to the C-section table. And so what we discovered is what we need to do is have extension cords, so that we have extension cords now attached to our IV pole so we can easily plug it in and raise the bed if the obstetrician forgets to raise the bed. And that was only identified by doing these simulations. This is a sample of the debriefing, and there are multiple ways of doing debriefings, but what we focused on again was our system, looking at not how individuals performed. We did not care who was there that day. What we cared about was what failures do we have? If you look on the right, what failures did we have? And what were the things, brainstorms that we could get from the people of how to fix those failures? And then we would compile these and go through them and teach them. And over time, we continuously made changes over about 2.5 years, putting them all together. By the end of it, we had a process in place where people had simple instructions of what they were supposed to do. So there was one nurse, for example, that would do these jobs, and one nurse would do those jobs. And on every shift, one person was assigned to each of those jobs, and they would review them, and we would do our stat C-sections. And by the end of this process, the volume in a stat C-section was so quiet that I could actually hear the count happening across the room. When we looked at the different types of errors, what we saw on these programs, and these were all different types of errors, were that there was a reduction in the basic number of errors. And the important part here is not that if you practice something you can do it with fewer errors. The important part here is that one group did something, we instituted changes, and another group would have fewer errors. Right? So that the lesson was going through the program, through the entire process, through the system, not through individuals practicing and getting better. Similarly, when we looked at our videotape programs, what we saw was there was a significant reduction in time from entering the operating room to time when the simulated incision would actually occur. Right? That's great. That was the problem in that one case. There was a 15-minute delay from entering the operating room to making incision, delivering the baby. This was a significant reduction. No one really cares too much about significant reductions on simulations, right? this has to have an effect. And the big problem with simulation is very few people have demonstrated that simulation can actually impact clinical changes. It's an assumption that we have in all of our programs. So what we then did is we just recently went through several years of our stat C-section. So we looked at all the cesarean deliveries that we had in our program during the time of this training, and we had 2 obstetricians go through and determine which C-sections were actual C-sections, stat C-sections, and which were those that we went into the operating room and said, okay, slow down, we can calm down here, right? Sometimes they call a stat C-section, we get into the operating room and the heart rate's up and everything kind of calms down. We still do the cesarean, but it's no longer stat. And what we found was that over the course of this 3-year period, there was a significant reduction, 30% reduction, in the time that it took to get from entering the operating room to making skin incision in the cases, real cases of stat cesarean delivery. More importantly, there was also a significant reduction in the variation of this time. Look at some of these cases, as I showed, took 18 minutes to make a skin incision on a stat cesarean delivery, right? This is where people, the process that they were using wasn't aiding them in getting the patient and the baby out in time. We've all seen these kinds of cases. We were able to reduce the time that these cases took because the system was streamlined in order to make facilitate that process. In conclusion, errors, mistakes will happen. People systems are fallible. Things will happen. Our job is to minimize the number of errors that occur. Our job is to reduce harm from those errors when they do occur. And you need to have a QA system. They're necessary. You have to have targets, and you have to understand the limitations of the QA system are also something which are very important. You are working towards a QA system. You're not necessarily going to improve healthcare processes. You're just going to improve the things that you're measuring. QI systems are things that everybody can do in every center. You can apply these approaches. They're tools that exist that have a specific task or purpose that you can apply to individual things, right? We use different types of QI models in order to fix different types of systems in our program, and everybody in this hall can do the same thing in your own program. I thank you very much.